Good evening and welcome to tonight's webinar. It's going to be focused on Infinity with Adaptis technology, which is the next step forward for our market-leading Infinity total ankle system. My name's Nathan Moore and I'm with Wright Medical's Total Ankle Marketing Group. We are so excited to have all of you here to discuss what is our latest innovation in the total ankle segment, Infinity Adaptis, which is going to be going into full commercial launch nationwide in September of this year. Incorporation of this new Adaptis technology has been in the works for over 10 years. And through recent advancements in manufacturing technology and a lot of hard work, we are thrilled to provide you with the market's first 3D printed total ankle system. So during tonight's webinar, our surgeon faculty are going to walk you through some of the different enhancements of the new Infinity Adaptis system, like improved long-term fixation via 3D printed porous metal components, increased initial stability that you're going to get through greater friction at the bone to implant interface, and improved wear resistance of over 26% with our new Everlast highly cross-linked polyethylene inserts. Along with that, our faculty will also share some of their early experiences, thoughts on prosthesis selection, and other important factors for you to consider as you begin to integrate this exciting new technology into your total ankle practice. We are fortunate tonight to have three highly experienced total ankle surgeons with us as our faculty and presenters. Our first presenter tonight will be Dr. Hodges Davis, who joins us from Ortho Carolina and Charlotte, North Carolina. Dr. Davis has been in practice for 30 years and has authored over 160 publications on the topic of foot and ankle surgery. Throughout his career, Dr. Davis has been widely recognized as one of the most experienced thought leaders in the total ankle space, implanting over 850 to date. Dr. Davis is also Wright Medical's Chief Medical Officer, aiding us in the development of new technologies, services, and medical education programs for foot and ankle surgeons across the globe. We're also pleased to have joining us Dr. Scott Ellis from the Hospital for Special Surgery in New York. Dr. Ellis is currently appointed as the Associate Professor of Orthopedic Surgery at the Weill Cornell Medical College. And some of Dr. Ellis's many accomplishments include winning the AOFAS Mann Award for Best Clinical Paper at the AOFAS meeting in 2014, being named president of the AOFAS Orthopedic Foot and Ankle Foundation, being recognized as one of Castle Connolly's top doctors in the New York metro area from 2015 to 2020, as well as being recognized as one of New York Magazine's top doctors in 2017 to 2020. Glad to have you here with us this evening, Dr. Ellis. And then lastly, we are fortunate to have with us as well Dr. McCormick, who is the Associate Professor and Chief of Foot and Ankle Surgery at Washington University in St. Louis, Missouri. Dr. McCormick has served as the Program Chair for the AOFAS Annual Meeting in 2017, and he's currently a member of the AOFAS Orthopedic Foot and Ankle Foundation's Board of Directors. He is also consistently recognized in the annual Best Doctors in America, and he's been published numerous times in widely recognized journals such as Foot and Ankle International, Foot and Ankle Clinics, the American Journal of Sports Medicine, and many others. Thank you for your support tonight, Dr. McCormick. So before we get started, just a couple housekeeping notes. Just number one, all attendees except for the presenters will have their audio and video muted for the duration of the webinar. There is a Q&A button at the bottom of the screen, which you can use to type questions to our presenters. Our faculty will monitor those as we go along, and we'll certainly try to answer as many of those questions as they can before the end of the webinar. And finally, just note that this is being recorded for later use on our Virtual Learning Center website. So again, thank you so much for joining us. I'm gonna go ahead and turn it over to Dr. Davis to get us started this evening. Dr. Davis, I think you're muted.
Yeah, there we go. Thank you, Nate. Very impressive. I feel like at this point we can just take a knee and and rest on our laurels. But we do have work to do tonight. It is my role in this quite auspicious panel to talk about technology. It's something that I'm passionate about because I believe that as we advance technology, we advance the care for our patients, and that's ultimately what we're about. So what's new about this version of Infinity? And one of the things that's new is the Adaptis technology. Our goal with providing an ingrowth surface was to improve long-term fixation using a 3D printed porous metal component that is not centered on, but is in one block. The second is it's our field with the coefficient of friction. With greater friction, we get better initial stability with and without cement. And then finally, our goal was to increase wear resistance, and that's when we start talking about highly cross-linked polyethylene, and I'll unpack that later. So when we started the design of Infinity initially, back in 2010, this is a memorandum and notes, and often when you start a design project, you say, this is our problem, how do we fix it? What are the must-haves and what are the need-to-haves? And in that meeting back in 2010 in May, we felt that some type of ingrowth surface was absolutely essential, and that would be a differentiator. And the second was prophecy, and we'll talk about prophecy a little bit later, but we know that that's clearly become a market differentiator as we move forward with that. And we had to make a choice because we did not have the technology to put the ingrowth surface on the implant that we were designing. So we always wanted to do it, but at that time we did not have the technology to 3D print it. We couldn't figure out a way to put ingrowth surfaces that were truly ingrowth on. We knew that we wanted something prophecy enabled, and we felt like that was probably more important. We've been talking about a poly upgrade for a while, as well as something different than the present flat cut tailless that we have now. And then we truly believe that the interchangeability between Infinity, InBone, and Envision and back and forth is important. And so what I like to say is these were our dreams, and finally the technology is caught up. So how did that happen? Well, the history of the Adaptis technology in 3D printing started with the Tournier shoulder. And as you know, Tournier and Wright merged a few years ago, and all of a sudden we had technology that we did not have before, and it was called Adaptis, which was integrated porous metal in a 3D printed fashion that was not put on at the end, but was present in a block. And so with that, we had the ability to now say, well, we know we can do it in a total ankle, and the bearing surfaces on a total ankle, on a total shoulder are very different than a total ankle. Can we do it on a total ankle? And so what is important about this Adaptis 3D printing techniques? It's extensive clinical literature with over 20 years of published experience. It's benchmarking competitive technologies with extensive reviews, and the process has been developing over the course of 20 years, leveraging the core competencies of 3D printing and ultimately coming out what you're going to see tonight. The type of 3D printing is called direct metal laser sintering, but basically you've got some powder, titanium or cobalt chrome, and it produces a part layer by layer. The laser beam sinters a titanium metal powder, and the porous and solid sections are built as one piece. There's no bonding process. This is a block. The innovative manufacturing, this is from the factory in showing the shoulders, has allowed us to do it in a way that we can do it quickly and responsively, so that we won't have back orders and all the other things that we sometimes do when we have to send parts out to have something done and treated. The proven results, first with rabbit implantation, and then we have a long results with shoulder replacement. The comparison to titanium plasma coating and this Adaptis technology demonstrated significantly more bone growth at 4 and 12 weeks with an integration of bone and tissue into the structure, into the block. All samples demonstrated bone ingrowth at or near maximum depth, as you can see from these pictures. In addition, the bone integration went into the struts on the porous surface. So in fact, when the bone integrated, the whole construct becomes stronger. And this is an image at 4 weeks from the rabbit study. So what do we get with additive manufacturing? And you know what, why as a doctor do I really care? I mean, what I'm doing is really good. My patients do well. What are the benefits? Well, I'll tell you that the added benefits are first, integrated porous structure. So you have a block. So you don't get any kind of delamination that we see in porous as well as in centering, which we've seen in other implants. Competitive, complex geometries. So what our engineers tell us is if you can dream up something, we can make it with this technology. And that has created all these things that these innovative total ankle surgeons can do. Optimizes porous substrate coverage. So basically we can put the porous surface where we want it, where it has the best chance of bone ingrowth and where it's needed. We can do porous pegs with a solid inner core, even on the smallest part. As you're going to see that we've been able to create porous on the pegs, which is created, we've been able to do longer pegs with porous ingrowth. We can do solid struts built into the substrate, which gives us strength. It gives us supply chain flexibility, which what it matters to me is I get no back orders. I get no questions by saying, well, don't put a 2 in this patient because we don't have any 2s. And then I can do it with the material that I want. So we can do it with titanium and we can do it with cobalt chrome. And so material science in orthopedics has revolutionized things. And porous ingrowth fixation, we know, has revolutionized hip replacement, basically making a hip replacement exactly what you want. In addition, we know that the development of porous materials for osseointegration has revolutionized the field in orthopedics in general, particularly with joint reconstruction. So the question is, how is it different than the current Infinity? Note, it's the same implant profile, the same size range of poly, tibia, and talus implant, the same prophecy scans, as well as the same instrumentation. So you don't need to learn anything different. So side by side, what is it? The posterior peg length is increased in length and ingrowth surfaces added to the smooth pegs. That is that initial stability as well as added stability at right when you. We know that the Infinity is grit blasted on growth surface. The Adaptis technology gives us 3D printed ingrowth surfaces, completely different type of bone surface interface. The Everlast Holly Crosslink polyethylene is different, and I'll talk about that next. The 3D printed monoblock metal components are there on the talus, where before it was forged and coated with plasma spray, requiring a second manufacturing phase. What about the flat cut talus? We have always been concerned, in particular in small patients, putting that big 10-millimeter stem that we have to do using the in-bone talus. This has harmonized stem diameters that eliminates the need for in-bone instrumentation and reduces the steps. The central stem is shorter, which eases implant placement and minimizes the risk of subtalar joint violation. And the monoblock design eliminates the need for back table assembly. So when you're ready, it's much quicker. But what about Holly Crosslink polyethylene? So Everlast polyethylene leverages the strength of what we know of normal polyethylene resin to support higher loads and contact stresses associated with the ankle joint. And basically, it's blended with vitamin D, which lowers the risk of oxidation while not significantly impacting the crosslink process. So what this shows is that we will have less potential osteolysis with particle oxidation and allowing that. In addition, based on wear testing, a 26% increase in wear resistance. So it's our hope, it's our belief, based on all the science available, that we will improve wear resistance and decrease the chance of polyethylene-driven osteolysis. It uses vitamin E to stabilize the material for oxidation, which is much better than centering it, and it allows the posterior and anterior lock detail shear to be greater than in standard polyethylene. It's cross-linked at a level that improves wear resistance without affecting the mechanical properties, which is exactly what we want. So the Adaptis technology associated with this new version of Infinity is 3D printed porous metal components designed to act as a scaffolding that facilitates bone ingrowth as early as 4 weeks. Increased initial stability through greater friction, 3D printed as a single monoblock construction where it reduces the possibility of delamination, and the Everlast highly cross-linked polyethylene improves wear resistance by 26%, and the vitamin E infusion minimizes the oxidation. The point I will make about vitamin E is the Everlast poly is a little yellow. So you can see that on the slides, and that changes it. All of this is powered by Prophecy. And those of you who are on the call who have not tried Prophecy, we've done almost 24,000 procedures in Prophecy. The experience we have gained through Prophecy is phenomenal, providing the surgeon with detailed surgical planning and patient-specific guides with accurate implant alignment. It has been written up in multiple journal articles as shown to be 38 minutes faster, 100% post-op neutral alignment, and it can create $2,500 reduction in operative costs because of the speed. This is patient alpha, 15 months out from an Adaptis, and you can see how well everything looks. And this is the close-up, and you can see how the implant looks like it's well integrated both on the tibial and the talar side, and the patient's at full activity. So the take home is the continuum of care is not just marketing. And the goal of Wright Medical has been, since I have been designing total ankles with Wright Medical, to continue to make the offerings better. Prophecy, Infinity options with a block talus and a flat cut, InBone, Envision, and everything in between to mix and match these implants gives us the greatest array of implants in order to take care of our patients, because we all know that the ankle arthritis patient for one side is completely different for the other. It's been a long time coming. Infinity with Adaptis technology and Everlast Poly is something that those of us on the design team for 10 years have been looking forward to and working towards. It is my belief that this takes a great implant and makes it better. And if we can do that, our patients are the ones who benefit. All right, Scott.
Sorry, Hodges, I'm trying to figure out how to just share my talk here. Okay.
Just push share screen.
Yeah.
There we go. You go.
I think we got
right
it.
there.
Okay. You'd think I know how to do this. I've done like 500 telemedicine visits with this. It's just slightly different when you go to the presentation. Okay, so
yeah.
Can you see my presentation now?
Yeah, you're good.
Okay.
You're good.
Okay, great introduction. Thanks for having me, everybody. I feel like in a way I'm going to be saying a lot of similar things to Hodges. I think what I've been asked to add, and I think what I can faithfully add, is my experience in total ankle replacement and how that leads into how I think this new implant with these advances is going to be amazing for our field and our patients. And just as a disclaimer, I started, not really a disclaimer, but some background, I started putting total ankles in fellowship back in 2007. And I feel like that was about the time when we were really turning the corner on total ankle replacement, where it was becoming a viable option. And I feel fortunate because I've seen the evolution of some very good implants. I will say that the Infinity is my go-to, and I hope to show you how I've come to that decision over time. But I want to show you kind of what my evolution and experience using the different implants has been and how Infinity fits into that. So, back in 2007, when I was in fellowship, we really had two implants. There's the Salto Talaris, which was the non-mobile bearing version, of course, of the Salto, which was at that point owned by Tornier. And the in-bone was the other available. And we kind of had lumped them into two groups where we kind of used Salto Talaris for the patients that weren't as heavy, less deformity, in-bone, probably heavier patients, some deformity. I think both have stood the test of time, so I'm not sure you can really lump them into those buckets, but there were some key advantages, at least at the beginning, that we saw to those, or for each of those. So this is a picture of the Salto Talaris implant. Some unique features that it had was this keel that allowed for rotational control and some ingrowth potentially along this barrel that went from anterior to posterior. The claim to fame always was there's this radius of curvature that was different for the medial and lateral talus, so it's more anatomical. There's some debate about what the radii of curvature really are. One unique thing was that you'd put the talus in and then you would ream the hole for that keel after you allowed the talus and tibia to sit in their appropriate rotation so they were matched. And there has been good medium to long-term data. And actually, we've published our series, or had accepted a series of our medium-term follow-up Salto Talaris patients that should be coming out in Foot and Ankle International soon. A couple of disadvantages that we saw was that keel, and it's not shown in this picture necessarily, would create some stress shielding. And so you'd see cysts formed around the keel. And in fact, right after fellowship, I went to France to visit with Michel Bonan, who's putting in the mobile bearing version. And they were always worried about cysts developing. And we're constantly getting CAT scans. So it's something I always had in the back of my mind, and would see more and more of that over time. I've always felt that the potential for ingrowth along their surface is a little bit less, and I just had this sense that I had more patients with impingement, although that's really anecdotal. So I have to say, here's a case that we did early on. They've done well. The instrumentation was good. It's not great like the Infinity has been, but it was certainly a good start and advancement for our field. And really, I will say that most of those patients that we put those in are still doing well. And that's what we found when we looked up our data. Again, we just had that accepted for publication for medium to long-term follow-up. The other implant I said was available at the time was the in-bone. This is an implant that's really stood the test of time, and I've always marveled how ingenious it was to design this kind of implant and the way it was put in. But its advantage is it has this very good coronal plane stability, has excellent fixation due to the stems, and for some reason has avoided impingement, probably in part because you can put bigger polys in and it stretches out the ankle, and I just see less impingement inferiorly in the gutters. The jig has been, though some would complain, cumbersome. It's essential and a great tool to line up deformity and correct it. Potential disadvantage is it takes more bone, and a lot of people will think of this as a revision implant, which is not necessarily the case. I think it's still well used in heavier patients, and again, it stood the test of time. Here's a patient early on of mine where we did an in-bone, and by the way, we're also looking up those medium to long-term results, and those are doing very well as well, and hoping to get that published as well. So those were the two early ones. I've had the advantage at our hospital being involved with other implants. The trabecular metal, one of my colleagues, Jonathan Deland, was one of the designers of this implant. So I did a number of cases with him. And the touted advantage of the Zimmer was also that it was a trabecular metal, or a good implant for ingrowth surface. Now, it was not 3D printed, and it was a ingrowth surface which was laid on top of their implant. So it is not the same technologies you're seeing with the Adaptis. But theoretically had that advantage. This implant was a little bit more cumbersome to put in. It's done from a lateral approach. You have to break the fibula and get it to heal. It seems to avoid impingement more the way the implants put in. The design was pretty anatomic. And really, you didn't go through the front of the ankle, which theoretically would avoid some of the wound healing problems and avoid the bone to load on the surface of that implant in a more anatomic way. But as I said, the problems I saw with it is you had to cut the fibula, and the lateral approach was difficult. It also became difficult when you were revising it, and certainly made, in my experience at least, the operating time longer. And I've seen a few cases now where the tibia would loosen. It's just, if you don't get ingrowth, those pegs are not, they don't have great fixation. A couple other implants, of course, that we've seen come down with time that I have some experience, and I have to admit not a lot, is the Cadence. I've done a few cases with this. It has this theoretical advantage of having a tibial base plate and a sulcus in the tibial component to accommodate for the fibula. And they designed a number of different polyethylene or plastic implants to address sagittal deformity. The Vantage, which also has come out more recently, again, I don't have a lot of experience. The touted advantage there is they have vertical fixation for the pegs and theoretically resist shear forces better. And there's an anterior flange to the talus, which can help in terms of fixation on the top. And there's some ability to mismatch components more. I personally think, though, when you take the whole package together, like Dr. Davis has said, and you consider the instrumentation, the ability to interchange between implants, and now the new technology, the Infinity has so many advantages, not to mention prophecy. I would encourage everybody to use the standard instrumentation because it's very well done. It really allows you a lot of control and can put the implant in well. Once you get accustomed to that, I think that's the time to start using the prophecy. There's no question it saves operative time, but you always want to be able to abort prophecy if you felt like you needed to and be comfortable with the standard instrumentation. Hodge has already talked about the 3D components, how they're printed. They get better ingrowth, and theoretically less potential for delamination and better ingrowth. That's the literature, and I'm going to show you or talk about how I feel like it's been in my own hands. This is the Infinity, the previous component that he showed as well. Again, a well-designed implant that was you could use with both the Infinity or the in-bone talus. It had these 3 pegs above and different variations in the tibial tray, and some ability to interchange the tibia and talus sizes. This is an example of an early one that we did that has also stood the test of time. Patient's doing quite well now, about 3 or 4 years out. We've done some research using the Infinity, and it's funny because this was our kind of early outcome study, and we really, because you can't assess too much at early outcomes, titled the study the short-term complications, reoperations, and radiographic outcomes. So I think it kind of is a little bit misleading because we really didn't find that many revisions. There was not that many complications, and when you compare it to other implants, it has a very good survival profile, especially early on. But my take home from our own study was that it's an implant that did very well at the short term. And I will say this, the few failures that I've seen have been on the tibial side. And I think the longer pegs with the ingrowth surface are going to really help dramatically reduce what already was a low number of failures there. Dr. Davis mentioned this also. We did our own study looking at the accuracy of using prophecy. It was very accurate. We had a number of cases where we modified the plan slightly, and what generally in our hands we found was that we would downsize the talus component just slightly, one size compared to what was given on the report. So that would be considered a deviation from the prophecy protocol, but was a minor thing because it was just a one size downsizing. Here's the new Infinity. Hodge has already shown this. He's talked about the pegs in the interchangeability between the in-bone talus and the Infinity talus. So I won't go into great detail. Here's one of the cases I've put in, probably about a 6-month follow-up now, and doing great. The implant well flush to the surface, and you can already see, at least the way I interpret, good bony ingrowth. So to date, I've put in 10 cases. It would have been a lot more if it weren't for COVID. I really can tell you, when you do the case, you don't feel any different than when you're doing the standard or older version, if you will, of the Infinity. Everything about the prophecies is the same. The instrumentation can be the same. I will say, when you go to put that implant in, those pegs are longer and they have more friction, and it just feels like it's fitting tighter. And so that was one concern I had earlier on, is just when you're impacting that tibia, you're relying on those 3 pegs, but now it just feels a lot tighter and a lot better. It just feels easier for me to impact them into position. Another potential, huge potential advantage is for earlier weight bearing. I generally have not allowed patients to weight bear until about 4 to 6 weeks. But with this now, I'm going to 2 weeks. I start them off in a splint and then progress them at 2 weeks. And really, the implant has capitalized everything I've liked about the Affinity. It's the instrumentation I like that I stress that you should learn and know. The prophecy is my go-to. I use it on most cases. And it really allows for accurate implant alignment. And then, of course, it's the whole portfolio where if you need to, you can use that in-bone talus. If you need to revise, you go to an in-bone implant. And of course, for more significant revisions, the Envision. And just understanding the product line helps you adapt between those very easily. These are the advantages that we're citing. And as Dr. Davis said, this you have to know or believe from the literature. I can't help but believe it's going to have better ingrowth and fixation, which they've shown too. And as I said, when you impact it initially, it just feels better. And of course, you gotta like the potential for better polyethylene wear, because these implants are here to stay for the long term. And we're going to want them to perform well 10, 15, 20 years down the line. And so with that, Jeremy, I'll turn it over to you.
All right, thanks, Scott. If you don't mind maybe stopping your share, please. All right. All right, I think we should be all set there. So, yeah, I certainly appreciate being included in the webinar tonight. And, you know, my thought with my portion of the program tonight is to help us apply some of the information that we've learned from the previous two talks as far as when to use which implant and how best to apply it to our patients. If we look here, this is a 73-year-old male, a patient of mine with post-traumatic arthritis. He does not have any deformity. He's got reasonable motion through his subtalar and talonavicular joints, and we see clearly end-stage arthritis. And so in this patient, I elected to do a Prophecy Infinity tibia with in-bone flat-cut talus, and here he is at 3 years post-op doing fairly well. Shows a minimal resection tibia component here. This is a quite different patient, 73-year-old female who presents with ankle pain, but she's got a very complex situation. She's had a previous attempt at double. She's got a stiff valgus ankle. You can see significant bone collapse at the lateral talus in a non-union of her talonavicular joint. So this particular patient needs 2 operations, corrected the deformity in stage 1 and then total ankle replacement in stage 2, but this is an in-bone choice. And this was because of the deformity, because of the stiff joints surrounding the ankle. Unfortunately, she's at 2 years now doing well. So how do you make these choices? Well, I think you have to consider the host. Look at deformity, look at bone quality, look if there's any adjacent fusions or any stiffness inherent within the ankle, and recognize that one size does not fit all. And I think it's important that we tailor our implant choice based on the patient factors. And again, as has been said previously tonight, that's where the right medical portfolio, in my view, offers a significant advantage. And here is that portfolio as we move from Infinity total ankle to Infinity with a flat cut talus, in-bone 2 total ankle, and then Envision, largely for revisions, but some primaries. And as we pointed out tonight, we've got a new toy to play with, which is Adaptis. And I don't mean that lightly. This is a new technology that I think is going to change the game and for all the reasons that have been mentioned thus far. And I think it'll fit nicely into this continuum. So as we look at a total ankle replacement algorithm, we'll look at the background information on the design features that we think are important, and then review an algorithm for treatment for each of the different components within the portfolio. So as we look at background, I think it's important to understand what the implant design goals were when designing the initial Infinity implant. And that was to completely replace the articulating surface, locate the correct axis of rotation on the talus, achieve a functional range of motion, and maintain ligamentous stability. And the goals with implantation were to be precise with reproducibility, have stable fixation that would offer longevity of implant for the patient, but also potentially could have some application for complex deformities. The thought was that a resurfacing total ankle replacement would have theoretic advantages for longevity and importantly for revision if there was bone to work with. Now these are not the same patient, but one can clearly see that there's more bone work done with an in-bone than with the Envision. The design goals, importantly, were never to replace in-bone as a primary. The goal was to create a new system that complemented the in-bone. For ease of use, that was prophecy enabled with minimal bone resection that would optimize stability, have a bone implant interface that would be visible on x-ray to understand if there was cyst formation or loosening, and again, would be compatible with in-bone, but would not necessarily replace in-bone. And so here's the picture we've seen tonight of the Infinity total ankle replacement that was a resurfacing implant designed to meet these needs. Well, we had to figure out if it worked, and Wright has been very good about trying to examine their own implants in a patient population in the United Kingdom. And this was a study that was a cohort study of patients with Infinity total ankle systems that were implanted either with standard instrumentation or prophecy. And the goal was to have 500 patients and follow them out for a total of about 10 years. They were done at 11 specialty centers throughout the United Kingdom. The first was implanted in April of 2016 and the last of November of 2019. And this data has really been good data. In fact, it's been recognized as a Roger Mann Award finalist at the AOFAS meeting coming up here this summer, where early outcomes and complications are going to be reported. The current follow-up status of this cohort of patients is that at 2 years now, there are 237 patients who are at 2 years of follow-up. And we'll see that this slide will progress, obviously, as time wears on. So nearly half the patients at 2 years, and certainly almost all of them at about 6 months follow-up with the latest collection of the data. The demographics are shown here. Mean BMI was about 30. Males, a few more than females, with a mean age of about 68 years old. Primary diagnosis was degenerative arthritis, post-traumatic arthritis, and rheumatoid arthritis in declining numbers. The COFAS classification was obtained to try to help understand the complexity of the ankle arthritis that was being treated. Most were type 1. And varus and valgus were treated equally. Average for varus was 9.7, average for valgus was 9.6, and the max was about 25 degrees in the cohort study. Patient-reported outcomes were measured, and at 2 years, for that group that's out to 2 years, we find that there's been an improvement in ankle osteoarthritis scale and an improvement in scores with a Eurogal quality of life and a Manchester-Oxford foot questionnaire, which admittedly are not questionnaires that we're as accustomed to seeing and using in this country, but measure patient outcome much like any of these scores would. Complications were recorded, and this is important. There was 1.6% malleolar fracture rate, so a few more than 1 in 100. Post-operative complications were noted for deep infection at 0.2%, so very few. There was 1 transection of a tibial nerve, which was managed with an interposition graft, 3 pulmonary emboli, and 7 deaths, which were noted to be unrelated to the total ankle procedure. So using this data, a fairly low risk of complication. Looking at reoperations and revisions, there was 1 planned reoperation for a staged cavus reconstruction, and there were 7 patients, only 1.4%, who had an unplanned surgery. 1 was a metatarsal osteotomy with lateral ligament reconstruction. There was some soft tissue failures that needed attention, a subtalar fusion, and then 3 surgeries unrelated to the ankle replacement. The revision rate is low. Now, granted, again, this is not all out to 2 years yet. So in the early phase of these patients, the revision rate is low. There were 3 that were revised for metal components and for aseptic loosening, fracture, or malposition, and 1 that was revised for infection. So importantly, what we're learning is that the Infinity system seems to work, at least in the early stages based on this study, and certainly in my hands with experience. With experience also comes wisdom. Both systems, meaning the Infinity and the in-bone, are essential to take on all shapes and sizes, both straightforward and complex. And I think what's important is that we can't be hammers looking for a nail. We need to be able to incorporate the Infinity, now with Adaptis, the in-bone, and the Envision into our patient portfolio so that we understand who to match the best implant with. So let's look at an algorithm for treatment, Infinity tibia and Infinity talus to start. And that typically is going to be your young patient who's got a low to moderate deformity, is typically less stiff, and does not have any semblance of neuropathy, an otherwise fairly healthy patient. This is a patient that Hodges has shared with me, a 61-year-old female with ankle pain. She failed microfracture 3 times, has normal motion and normal alignment. And you can see on CT that she's got a cyst in her talus. She's got some bone edema and cystic formation in her MRI. Again, she's failed 3 previous surgeries, and she elects to proceed with a more definitive procedure. Now, here's the prophecy generated report. And for those of you who have not used it, it's important to take some time to review this carefully. It offers a lot of information that I think can be quite helpful in preoperative planning. And then at 4 years post-op, here's this patient, fortunately doing quite well with good bone ingrowth in the more standard Infinity without the Adaptis. In looking at Infinity tibia with in-bone talus, Typically, for me, that's a talus that's going to be more of a flat top, a little bit stiffer joint where maybe a little bit more bone resection allows for better gutter debridement and a little bit better post-op motion. If there's a more complex tibia deformity where I want to have, again, a bit more room to work for deformity correction, and if there's hardware challenges where we can't put an in-bone in the tibia side because there's retained hardware, but we want to try to maintain the flat cut on the talus. Honestly, for me, and this is why I showed Hodges' patient first in that infinity tibia, infinity talus group, for me, this is most of them. In my hands, I find the flat cut talus a bit more reproducible. I find that I can find the center of rotation a bit better, where I can have a flat surface, range the ankle through a bit of a range of motion to allow that talus to find a sweet spot. And so that is my typical preference, but certainly can be biased, admittedly, for where I've been most comfortable. Here's an example of an 80-year-old female with post-traumatic arthritis, valgus alignment, and limited dorsiflexion. And in her, I chose a Prophecy Infinity tibia and in-bone talus. And here we see intraoperatively the flat cut on the talus that allows a bit more room to work and a fairly reasonable outcome there radiographically. Now here she was at 6 weeks doing well, and here she is at 9 weeks having fallen with a fracture. And certainly that's a disappointment to any of us who do ankle replacement surgery. So we went back to the operating room for ORIF, fixed the medial malleolus. Admittedly, I put a very stout plate here, maybe overkill, but I wanted to be sure that in this 80-year-old, even if the bone didn't completely heal or was slow to heal, she would have enough robust fixation to be stable. And here she is at 2 years post-op. Now, this got me to thinking, did I make the wrong implant choice? In this 80-year-old with potentially softer bone, should I have gone to a stemmed implant? Well, a stemmed implant seemed like a lot for her. And so here's where I started to wonder about something in the middle. So if we consider going to an in-bone tibia or in-bone talus, that's typically going to be patients in my hand who would have older, softer bone, larger patients with bigger deformity, a more stiff ankle or hindfoot. Maybe it's because of a hindfoot fusion. Certainly any revisions of primary minimal resection total ankles should be done, in my view, with an in-bone tibia and talus as a reproducible outcome. And if there's any concern for even a little bit of neuropathy or numbness in the foot, certainly a more robust implant with more robust fixation. Here's an example of a patient of mine, a 57-year-old male who had post-traumatic arthritis. Ankle was very stiff, and the screws were in the way. I was worried that I wouldn't be able to get these screws out. They were going to impinge against the infinity based on the preoperative prophecy planning, and if I had trouble getting them out and I had to bore holes over them, I didn't want to have tibia failure above a minimal resection implant. So I elected to do an in-bone, and here's an example of the Prophecy in-bone tibia and in-bone talus. It's a little different. There's a tibial stem alignment guide that's necessary here, and certainly something that really matches up nicely. The Prophecy does a nice job to be able to fit that appropriately as you work through the sequence, but it is a couple more steps. Here are OR pictures for this patient. Did the tibial resection, and here's an example of that alignment guide for the drill to go up. It still goes into the heel like the standard in-bone, and there's an outrigger that's used. But for this particular patient, I wanted to be able to bypass the holes for the screw. It was fortunate that the screws came out without any trouble, but I needed to plan for the just in case. And so here she is post-op. Here the patient is at 1 year, and here she is moving her ankle. And one can see that she's got really good motion, even with a more aggressive implant in a sense. She did very well. But here again is where I started to wonder about room between the infinity tibia and the in-bone tibia. Could we optimize tibia fixation without needing a stem? And here's where the Adaptis comes into play. I got to thinking about that 80-year-old. Maybe she didn't have enough fixation. Did she need a stem? The Adaptis, as has been mentioned, is this 3D printed porous surface that allows for bone ingrowth and what we think is really improved increased initial stability. Here's a patient that really got me scratching my head. A 61-year-old female with ankle pain, had normal alignment, and her DEXA showed osteopenia. I wanted a minimal resection for a patient who did not have significant deformity, but if you look carefully here, you see that I had to use cement in her tibia. So intraoperatively, standardly put the tibia component in, and it was rocking, it was moving. I didn't feel comfortable with the stability of the implant, and so I chose to cement it. And at this point, I'm wondering, there's got to be a better way. And here's where the Adaptis is going to really change the game. Here's a patient who's a 73-year-old male, and this was the first Adaptis for me of ankle pain, stiff ankle, mild valgus. And here's a patient where I was unsure about standard infinity fixation. Do I maybe need to go to an in-bone, but felt more confident to think that this Adaptis technology might give me an opportunity to still do minimal resection. Here's the Prophecy infinity tibia in-bone talus with Adaptis technology, the same instrumentation and same prophecy planning. And here's this patient post-op, and at 6 weeks, really looks like there's very good stability. You know, if you're looking through rose-colored lenses, you might even argue that there's some ingrowth, but certainly no loosening and certainly no concern. Again, very early out, but it helped bridge that gap in my hands between the standard Infinity and the in-bone. Here's a patient of Hodges. This was that patient Alpha. But you see here that the CT scan shows these cysts. And is there going to be concern with standard Infinity fixation? And we see that there isn't. The patient is well out to 12 or 15 months with good bony ingrowth. And then lastly, the algorithm needs to include a revision implant, the Envision. Certainly revisions should be used. The Envision should be used with revisions. You can use it with primaries, and that would be a patient with a tibia that has significant bone loss or poor bone quality. The talus has poor bone or a really flat talus that needs to be augmented. This was a patient of mine, a 67-year-old male with post-traumatic arthritis, had a pilon fracture, had significant bone failure at the joint, shortening and elevation of the joint line. And there was concern for all this screw holes that I had made at the first stage, removing all the plates and screws that were there. Used the standard in-bone with the Big Bertha frame. And the reason for that was because the prophecy team was unsure with all of the bone loss and irregularity that the prophecy would fit reliably. Used the frame, which works very nicely, drilled within the canal. I will admit to you that there's a little bit of malalignment of the tibia by a few degrees here, but this was the best we could fit, a thickened tibia insert. And the reason it's this long is to bypass all of these holes and all these drill holes that I made through the cortex to allow for implantation here. The patient's 2 years out, fortunately doing well. So my current algorithm we've reviewed, and I think what's important is to recognize that with the advent of the Adaptis technology, I think shortly my algorithm is going to change to be Infinity Tibia and Infinity Talus with the Adaptis technology, because I really like the early sense of fixation and stability. And then similarly, Infinity Tibia with the Infinity Flat Cut, and won't have to go to that large hole in the talus, and we'll be able to use the smaller pegs with more confidence in ingrowth. And then, of course, with the algorithm, the in-bone tibia, in-bone talus, and Envision systems. So the continuum of care, I think, has changed a bit. It's still Infinity, but I think now it's Infinity with Adaptis. And as we become more accustomed to this, I'm confident that we're going to have greater confidence in the implant with initial fixation and bony ingrowth, be able to tackle slightly increased deformity with this system. The take-home message is, importantly, that not all total ankle replacements are the same. We need to individualize implant choice based on patient factors, use the continuum of implants, and we will continue to improve, build on previous experience, and certainly the Adaptis is the next chapter in that voyage. Early feedback on the system, I think, has been very promising. There's been 260 plus cases with the Adaptis. Bob Anderson suggests that he's put in quite a few. Has been very pleased with fixation. The x-rays look good with no failures to date. Scott, who's on the webinar here tonight, has been very pleased with the early findings. Anand Vora notes that it's a more robust prosthesis bone interface with improved initial and long-term stability. And then John Lewis, another confident and comfortable user who has found that long-term component stability and survivorship should improve with this system. So again, as wrap up for the Adaptis, we think it's going to change the game here, allow a minimal resection implant with more confidence in fixation, particularly on the tibial side, improve long-term fixation as well, and hopefully we'll find that as we follow our patients out to several years, increases initial stability, as you've heard. And then, of course, I didn't touch on the poly in my section of the talk, but we think that the vitamin E enriched polyethylene will increase wear resistance and help reduce some of the cyst third body wear and backside wear that we were concerned we were seeing.